Okay, so this session, I'm hopefully going to have you end up feeling a little bit more confident about ECGs, so that if you've got one of those machines in the clinic, they're not just collecting dust and your boss is very happy that you're actually using it. Before then, with Dr. Singh just mentioning my little daughter, I thought I'd just show you what happened 2 months ago. So she did have a very large cyst, pretty much the size of her eyeball, in behind her eye, and we picked up on it when we were sailing up the coast because her eye started to be not quite the same size. We started to see a little bit more white on the on her left eye and just seemed to be bulging a little bit, and this is what the team found, and she had major surgery, and you couldn't pick it. She's a happy little thing. She made a full recovery, and her eyes will equal out, which we're very, very relieved about. So yes, there was a little bit going on before we came here. So look, today we're going to cover what is an ECG and why do we need it? What is the normal conduction of the heart, so that we understand when it's not coming through the normal pathway, what's happening. How to set that ECG up and get a good printout so you can actually do some measurements and make some sense of it. Interpreting normal so that you then know what abnormal is. And I'll go through some of the more common arrhythmias we see when patients are critical. If anyone wants a good reference, and if you're finding that ECGs are quite daunting, this is quite a concise and simple reference that when I was first learning, I found it quite handy because it has a lot, it steps you through interpreting. It has a lot of the common arrhythmias in it, and it's just one that you can grab by the bedside. You know, we have it in ICU, our nurses use it. It's a really quick resource. So ECG, we are getting a record of the electrical activity in the heart. We're using it to determine whether we've got abnormal or normal rhythm, and then that helps us guide our treatment. When we've got it, we've got the multi-parameter machines, which you're actually getting real-time monitoring, and the patient can move around. I'll step you through how we hook them up for that. Versus to get a printout, you can print out from these machines, they can come with paper. However, it's not as accurate as actually getting the proper right lateral and having a dedicated ECG machine that's just printing onto paper. But these are the next best. We set up with 3 leads. We also can do 6 lead, and our cardiologists can do 12 leads when they're really looking at a lot more of the idiosyncratic, like the finer details for us and everyday practice, and even as a criticalist, I'm quite happy with just looking at 3 leads. We use the little dots just to be, if they're in a crash patient and it's an emergency, we clip on, and you'll find the clips. We can just go onto the, behind each elbow and on the flank on the left. If we want it to stay on a little bit longer, we'll either clip the hair. You can put it directly on the pads if they're not recumbent and not walking. But as soon as they get up and start walking, they really hate things on their pads. So we actually just clip the hair from the pad up, and we stick those dots on, and then you put a little bit of Coflex or the vet wrap, and then that keeps the buttons. And most machines will come, and you can buy an extension by the new fly that comes across, and we always have a spare because dogs like to chew through these if they're left on them. We'll use alcohol or ultrasound gel, and electrocoupling gel, which I've got on another slide, actually gives you better conduction, but sometimes just your normal ultrasound gel will do. A blanket or a towel on the table. And we commonly use, if we're setting our speed, we'll try and do our normal speed we look at them on is 25 millimeters per second, but you can look at it slower if you really want to stretch it out and get a better view of it. The cheat way is you think of right, white, so it rhymes. So the right lead goes on the right forearm, and it's normally white. And your left goes on your left forearm, it's black, and then your red goes at the back. So it's just, once you remember that, you just do it the same way. If you put them on the wrong way, your complex just looks a bit funny and upside down. You don't let your electrodes touch. You don't want those electrodes touching any metal either. And yeah, as I said, alcohol or electrocoupling gel. They'll be in right lateral, and we want them calm. You know, we're not pinning them down for ECGs. And sometimes if they're dyspneic and they're struggling to breathe, we may not be able to have this happen. And just having them sit quietly, we can still assess the rhythm from that. Going through what's normal, and when you think of it that first, you know, we all see that the ECG, you know, wherever you know, they use that so commonly. But you think of what's actually happening. So you've got your P wave is your atrial depolarization. The PR interval is that delay, and the AV node is designed to slow things down. It's the delay for the conduction to go through your AV node. Then you have your QRS, which is your ventricles taking over and depolarizing. Then you've got your ST segment where they're recovering. And then you've got your T wave where your ventricles are repolarizing and coming back to baseline. So this is just a short video.
Heartbeat produces a regular identifiable pattern, the P wave, the QRS complex, and the T wave. These segments show the electrical activity of specific parts of the heart. The normal pattern of electrical activity that is seen on an electrocardiogram, or ECG, is called a sinus rhythm. The SA node is the normal pacemaker of the heart. It begins the heartbeat by producing an electrical signal. This signal spreads through the atria, or upper chambers of the heart, causing them to contract. Electrical activity in the atria is seen on the ECG as the P wave. The signal then reaches the AV node, which transmits the electrical signal that continues through the bundle of His, the bundle branches, and the Purkinje fibers. This causes the ventricles, the lower chambers of the heart, to contract. Electrical activity in the ventricles is seen as the QRS and the T wave. A normal heartbeat produces a regular identifiable pattern, the P wave, the QRS.
I think we're repeating there. So look, that's the real, you know, the crux of it really, is that's what we're seeing. So when we're wanting to assess and see whether we've got normal or an abnormal rhythm, going through these steps where you step through each one, you're looking at your rate, your rhythm, what are your P waves doing, what's your PR interval doing, is your QRS complex nice and narrow and normal, or is it wide and bizarre? So is it not coming through that fast pathway, instead it's originating from the bottom of the heart and doing its own thing and traveling much slower because it's not gone through that rapid conduction of your all of your ventricle fibers as they kind of all take it through. Your QT section, which we're not as worried about in dogs, then you've got your ST segment and then your T wave. Your ECG paper, you think of each of these little boxes as a 1 millimeter wide and 1 millimeter tall. The standard rate we run the paper, standard time we run the paper at is 25 millimeters per second, but you can make it run so you'll get 50 millimeters per second. And you'll get a better look. You know, sometimes we use that if we really want to look more detailed at each rhythm. If we were running at the standard rate, every little box is 0.04 of a second. So every 25 of the little boxes, or 5 of the slightly bigger boxes, is 1 second. Versus 50 millimeters per second, every one is half of that time. And it's every 50 millimeters is a second, so they're just stretched out more. And then your voltage is measured in your vertical, and your standard is 10 millimeters per millivolt. So to determine the rate, there's a couple of different methods. Common one is just to look at the 6-second strip and times it by 10. So you're either counting out, you've got to look at what speed your paper's in. You're either counting out 30 boxes, which is 6 seconds, and then you're counting how many P waves in 6 seconds, which gives you your atrial rate. And normally, in a normal sinus, there's a P, QRST, and so there's 1-for-1 ratio. You've not got anything different happening. So those two should be the same, versus counting the top spikes, how many top spikes of your R wave, which is your ventricle rate, in 6 seconds, and times it by 10. Another cheat way is kind of looking, and it's a bit cruder. It's only to be used if they're in a regular rhythm, because if they're irregular, it depends just on which RR interval you count. You work out how many large boxes are between your RR interval, and this is in a normal speed of 25 mils, and then it's 300 divided, because there would be 300 boxes in a minute, divided by the number of large boxes between. So an example would be, there's 4 large boxes in this top one, 300 divided by 4. It's a really rough, quick way of just getting a rough estimate of what heart rate that trace is. Obviously, if you've got the ECG on the patient, you're getting the number come up, but this is if you've done a printout and you don't have the ECG real time with you. Method 2, again, if you're looking at small boxes and trying to be a bit more accurate, you're dividing it, there's 1,500 small boxes, and you'll get the same rate. Determining your rhythm, you want to think, is it regular or irregular? So you're looking at the intervals between your big one is looking at your RR intervals, but your P wave's consistent through the strip, a Q wave's consistent through the strip, and then you look at your RR intervals. Sometimes using little calipers as well could really help you determine if you've got an irregular rhythm. And it's the difference, the intervals between your PR waves or your RR waves are varying. If they're varying more than 0.06 or 1.5 little small boxes. So that's what you want to really watch for. And if it's irregular, and that's sometimes with these sinus arrhythmias, normally with their breathing, it occurs in a pattern and it's reoccurring. So looking at your P wave, you want to have a look and see, is there a P wave present for every QRS? Is it smooth and rounded and upright? Sometimes they can be inverted. Are they occurring regularly? Do they all look similar? And is there one for every QRS? So you've got one-to-one conduction. Then you look at the PR interval, so how long it's taking to move through the AV node. Is that consistent or is it changing? And there's individual variations if it's greater than 0.2 of a second or less than 0.12 of a second. Begins with the P wave and the first deflection of the isoelectric line. And it so see that little marker where we're measuring it, and then it ends right where your QRS is about to start. And it's usually, so you're looking at the first positive blip right way through until it's about to go negative is how you measure it. You're going to evaluate your QRSs. So yes, we've got P waves, but do we have a QRS following each one? You're going to measure how wide they are, and if once they start getting bigger than 3 small boxes, that's they're wide. We're starting to call them wide. And are they looking consistent appearance, which we'll get into more when you get multifocal ventricular arrhythmias, where they're arrhythmias coming from different sites of the ventricles. They'll have different appearances, so you really want to look if they're consistent. The QT interval, it's how long does it take for the atria to completely contract. Sorry, that should be ventricles there. That's a mistake. It varies normally with heart rate, but it can be longer with slower heart rates and shorter with faster heart rates. Prolonged QT is a very big thing in humans, where some drugs cause prolonged QT, and it does make them more likely to be at risk of fibrillation. It's not as big of an issue in animals. And again, so this is something they really evaluate ST segments very closely in humans. We're aware of it, and it's a good thing to look at and get used to looking at. And you're looking at, it begins at the end of the QRS complex, and then it ends again with the onset of the T wave. So you're looking at what that section is doing. So if the ST segment is elevated or depressed, it may indicate myocardial ischemia or other cardiac injury. So they are looking at this, especially when people are having heart attacks. Your T waves is your repolarization. So is this happening at every QRS? Note the shape and the height and the amplitude. And are they consistent, positive or negative? Sometimes they can, they can be negative, and we're not as concerned. Your big one too is when you're getting high potassiums and tall and spiked tented T waves. So sometimes it's an early sign to say, go and look at your electrolytes, go and check something else. So your normal rhythms, you've got normal sinus rhythm, you've got a respiratory sinus, and then we just have simple tachycardias and bradycardias. I've got some cheat sheets as well at the end, which I've put in the slides, which I can make sure the PDF comes to you as well. So normal is, there's a P wave, you've got a QRS after each complex, and you've got your final repolarization of your T wave. Your rhythm is nice and regular. Your heart rate's not too fast, not too slow. So reference ranges for normal dogs, they vary across heaps of different textbooks, but large dogs are lower, smaller dogs may sit a bit higher, and then you've got your cat normal. And sometimes when you first hook up the ECG, it'll be through the roof. Let them calm down. And we've seen when we're running them on them constantly, they get up and have a drink or eat something, and their heart rate can spike over 200, and then they sit down and it drops as quick as it increases. So the respiratory sinus arrest is when there's got normal P waves and QRSs, but the difference between your RR intervals, so you'll have some, a short run of normal complexes, then there'll be a pause, and then you'll go again. This is all to do with vagal tone, and it's not actually an arrhythmia that we're worried about, but we know that there's probably high vagal tone, and it's going in and out with, it's varying with in line with the breathing. The sinus tachycardia, if we're seeing this, we're thinking, right, I'm in ICU, I'm thinking about, are they hypovolemic? Are they painful? This is persistent tachycardia, not just transient. And you're looking for underlying causes. There's normally something going on for them to be this tachycardic. If their heart rate's too slow, have we given them too much opioids, too much sedation? And that's another thing, is sometimes, especially medetomidine. So if you actually start putting ECG on these dogs that you're giving medetomidine to, you'll see quite a slow heart rate. And sometimes they're just asleep. So we'll move through some of the common ECG abnormalities. So AV blocks, so that when the conduction is going through your AV node, sometimes it's altered or slowed, and you've got all your different types of heart blocks. There can be a partial or complete failure for that to pass through the AV node, and the varying different degrees kind of step through all the way to third degree, where there's no association. Your P waves aren't getting through at all to tell your ventricles to go. So your first degree AV block is there's generally a delay in the conduction, and you can see the little lines here, just showing the P wave is further out from the QRS than it should be. The rate's generally slow. When you move into your second degree AV blocks, there's a progressive lengthening of your PR interval, and it'll get longer, and then it drops a beat, and you'll get a missed one. Your first and second degree AV blocks are generally don't cause any clinical issues. It's something to note. Sometimes different drugs, and we're monitoring for development. So your second degree, and within the second degree, you've got two arms. You've got your Mobitz type 1 and Mobitz type 2. And again, in the Mobitz type 2, you're getting where you'll actually, the PR interval is similar, but you're going to be getting frequent dropped complexes. This can develop into a full AV block, so you are watching, but often it can be drug or other underlying causes. If you want to if it is, we're seeing a lot of P waves without QRSs behind them, we're going to give some parasympathetic drugs. So we'll give atropine, and we'll see the response to atropine. Third degree is just there's no talking. So the P waves are chugging along, and the ventricular complexes, sometimes it lines up, and you think that P wave, like the fourth one here, you think that it's triggered it, but when you actually look, there's no rhyme or reason. There's nothing regular. So these patients can have syncopables. They can end up with very low ventricular rates, and they need pacemakers generally. Some dogs can live in the 3rd degree AV, and they just sometimes have some collapse periods, but they're at risk of sudden death. So a supraventricular premature complex means so it's supraventricular, it's above the ventricles, and it's happening too soon. And it's something where it's a premature contraction, and it's above the ventricles, so the atria has little bits going off. They've got normal QRSs, and they just happen too soon. You may or may not see a P wave. If you get a heap of these guys together, it's what we call SVT. So it's the really fast, narrow complexes, and again, certain disease processes, sometimes other inflammatory processes can cause this. It's not as common arrhythmia that we see, but we do definitely see it in some of our critical patients or the underlying cardiac diseases. It's normally really fast, so greater than, because you've got that fine line of what's just sinus tachycardia, and sometimes telling the difference between sinus tachycardia and this can be hard. This was actually a supraventricular tachycardia, and I did find an old video before we had our defibrillator, and you'll see this is our cardiologist, Fiona, we've been trying to convert this SVT into normal sinus, so you're trying to break that and get that AV node to take over again instead of this site on the atrium that's just going kind of crazy. We'd given diltiazem, and the effects of diltiazem can decrease contractility, decrease heart rate, and decrease your conduction velocity, which was what we were hoping to have. It hadn't worked. If you leave them in sustained supraventricular tachycardia, they can actually start damaging their own heart just because they're staying that heart rate's staying so fast. We had used esmolol, so a beta blocker, trying to slow this rate. That hadn't worked. And next step would have been a cardioversion with a defibrillator, but we didn't have it. That's a precordial thump. So
there we go, we broke it.
And it can work, but sometimes they flick back into that rhythm. She was I don't think we thought that was going. So see how it's gone straight back in. So it's temporary while you're trying to have your other antiarrhythmic drugs take over. Probably a common one that we see, and often you can pick this up by just listening to your patient. If you listen to their chest and it sounds like a washing machine with shoes in it and it's just all over the place, atrial fibrillation is at the top of my list. You're getting the atria is kind of going nuts, and not all of them are getting through, and there's no rhyme or reason. So you've often got irregular RR intervals. And when you actually look and measure, when it's really fast, it's sometimes hard to tell, which I've got an ECG to show you that. But you've got nice narrow QRSs. The amplitude can vary, but it's irregular. There's no consistent or recognizable P waves before any QRS. So this is one that's quite fast, but if you watch carefully, see how you start seeing variations. And this is me eyeballing it without even getting the paper off and measuring. It does it again up here. It gets a bit more obvious where you get quite a different seeded wider complex there between your RR intervals. But if you listen to this dog as well and felt the pulses, there's pulse deficits. It sounds really irregular is the best way to describe it. So paying attention to your physical exam and looking at your ECG in combination can really help. I've got you a slower AFib so you can really see the difference. And so even if you only felt confident with normal, you could look at this and go, because I know that one of my steps was to look at my RR intervals. They're different. This is not normal. And make you look further. I'll just briefly step through atrial fibrillation. And so sometimes this can be an underlying, electrical problem of the heart. And there's There's not definitively underlying atrial enlargement. Most of the time the atria is diseased and it's been stretched and enlarged, and that's why we've got this arrhythmia develop. If they call it lone AFib, normally structurally the heart is normal. Those are ones that we've actually do cardioversions on and can get them back into a normal rate, and they have a much better quality of life. If you've got a diseased myocardium and you've got a stretched left atrium, which is why it's happening in DCM, mitral valve disease patients, so underlying cardiac disease, it's normally managing them with medication. The aim is to kind of treat the underlying disease. So if they've got pulmonary edema and congestive heart failure, definitely starting them on that treatment plan will often improve you'll get better rate control, even by just treating the underlying disease. But the drug of choice, if we've got a very fast rate that we want to treat, we're giving diltiazem. Can you get diltiazem IV here? We can't in Australia, we only use oral. But you want to be careful. It's a negative inotrope, negative chronotrope, so it's going to decrease your conduction velocity. Again, I always just look up the starting dose rate in plums and treat any other underlying diseases, and go looking for, and if you have atrial fibrillation, go looking for cardiac disease. Before we move into the ventricular stuff, I just want to show you an escape complex. So if you've got a really slow rate, and sometimes if they're under medetomidine will commonly do this, you slow their atrial rate down so much that the ventricles at some point go, hey, I'm coming in here, but it's delayed. It's post when there should have been a complex, and that's just an escape beat. They're wide and bizarre, so it's not a VPC, it's an escape. So absent P waves, but it's a longer pause. Versus your ventricular premature contractions, they're happening too soon. There's a bit in the ventricles that is not happy, and so it's not coming down through your normal pathway. You don't have a P wave before it. They're generally wide and bizarre, and you can get left and right originating ones. So sometimes they go up first and then down. Otherwise, they go down and then up. So be mindful of the ones that are flipped upside down. They can happen by themselves. They can happen as couplets, so you get a run of 3 of them. You can have, couplets is 2, triplets is 3, or they can be coming from all different places, and they all just look slightly different morphology, which I've got some videos of. They can vary from happening just occasionally, and if that's happening occasionally, we're going to monitor, be looking at what's our underlying disease. Are they septic, inflammatory? Have we got a reason for that heart to be a bit pissed off, really? Versus, and what's progressing? Is this arrhythmia getting worse? It's starting to look more multifocal, or the rate is starting to get faster. You can get ventricular bigeminy, where it's kind of consistently taking over, and it's going beat for beat, one with the atria and then the ventricle, or trigeminy, where you'll get 2 normals and then one from the ventricles if you're describing these rhythms. The idioventricular rhythm, which is accelerated idioventricular. So this is a rate where some of these post-op GDVs are still in this rhythm. They're normally hemodynamically stable. We're not aggressively treating these arrhythmias because their rate, it's all the ventricles taking over. There's no P waves, they're wide and bizarre, but the heart rate's nice and slow. They've got good pulses, there's no perfusion deficits. So it's kind of like a slow VTAC, but we're not treating it. The grey area, like once an accelerated idioventricular, if it's starting to head up, sitting 150, flicking 160, I'm really watching it, because it doesn't take much for it to start affecting their forward flow and their output. So a lot of the textbooks, like I said, the last lecture is 180, but I'm kind of starting to worry a bit if it's 160 or above. Once it's getting fast and you see these, and this really clearly just doesn't look normal. Like if you're happy with normal and then you see this, you know it's not normal. It's a VTAC run is more than 3 VPCs together, and it can either be non-sustained, so you get little short bursts of less than 30 seconds. If it's going over 30 seconds, we call it sustained. And generally it can be a life-threatening arrhythmia. these guys we are starting to treat with lignocaine. This is the dog before that was in VTAC. You could see how fast this rate is. We couldn't feel pulses. This was an arrest rhythm, and we were giving lignocaine.
Converted with
lignocaine. And he converted. And sometimes you see these dogs kind of collapse. They have a syncopal event, and sometimes they'll go into VTAC, and that's those boxes that have those collapse episodes and then recover. And then they can come out of it themselves. It's once they fibrillate that they can't come out of it themselves. So and you'll see these dogs, they go into VTAC in the cage, and they know that they don't feel well and don't feel right. You want to reduce the risk of sudden death of going into that and then not coming back out or going into a fibrillation. IV lignocaine is our drug of choice. It's really slowing things down through the Purkinje fibers and increasing your refractory period. This is our cheat way of what we do. Everyone across the world of different cardiology teams are slightly different. Some always go 2 mg per kg straight up. We'll give 1 to 2 mg per kg. We're normally giving 1 mg per kg boluses and repeating. And we repeat every 5 minutes. We give it over 30 seconds, and we repeat that bolus every 5 minutes until we've got an improvement in the rhythm. But once I'm getting up to that higher 8 mg per kg, I've definitely got 6 or 8 mg per kg. I've got diazepam with me because lignocaine can make them seizure. And also, if you haven't converted them by the time you've given 8 mg per kg, don't keep going. You'll definitely make them seizure. We start reaching for our second lines. I'll start giving magnesium. The lignocaine does make them really nauseous. So if you had a dog that was looking quite well post-op, and we've had a lignocaine bolus him for his arrhythmia, and then he looks terrible immediately post, I explain that to the owners, and we're trying to get them off lignocaine as quick as we can because they won't eat on it, especially at the higher end of the rates. They're nauseous, drooling, and dull. It makes them feel pretty crappy. So magnesium is something I'm using reasonably commonly in these refractory ones, or if we're not responding well to lignocaine. We're giving a bolus of 30 milligrams per kilogram over. And it depends how worried I am as to how fast I go. Ideally, I like to give it over 15 minutes. And if you it's really hard to measure magnesium, especially ionized magnesium accurately. We can do it at the away low, but we're only getting total magnesium. So sometimes just treating, and there isn't a magnesium deficiency there. Sotalol is the beta blocker that we're using in these guys, and it increases the refractory period, so slowing things down. If that patient stays in fast VTAC, it can be indicated to a cardioversion, but you've normally tried your other drugs. This is before they've arrested. If they arrest and they die into a pulseless VTAC, definitely it's a defibrillation. So R on T is when you've got a VPC has happened again so soon that it's almost superimposed on the other ones. So your T wave, it's almost kind of on top, and you kind of think the ventricles are trying to depolarize and repolarize at the same time, which can lead to fibrillation. So this is an indication to treat, even if you're only getting a couple of them. I'll show you a video. I think this is a video. Yep. So you can see them intermittently coming through where there's a deep, like you see that M shape where it's just fast down, fast up. If you see that and it doesn't come back to baseline, that we would start treating with lignocaine. So when I mentioned before, like what we call malignant arrhythmias of ventricular ones, these are the things that are starting to make me think I'm going to pull out lignocaine. So faster VTAC greater than 160, that R on T. If it's starting to get messy and there's different complexes that are wide and bizarre, but they don't all look the same, that's multifocal. So I just know there's more areas of the heart a bit angry, and that's going to make me, and often as their disease process is progressing, you'll see it become messier and messier, and if it's progressively getting worse and not better, I'm more likely to treat. Short, fast bursts. So have a look at this. See that run there in the middle? It slows down. It goes normal sinus, and then it's back to that 160 rate.
Yeah. No, no.
But
faster.
that short, sometimes you don't get it. The machine doesn't catch up. Oh, I wanted to show you that again. That short bit there in the middle, it's just about to get overridden. Hang on, I'll play that one more time. Yeah, that bit there, I could see that's a faster rate, and my rate already is 160,
How long
so
is it?
that must have been a 180 or above.
No, no.
So we're much more likely to treat short, fast rates if they're starting to have collapse episodes or become sometimes they're hemodynamically unstable. I'm more likely to say I'd rather treat and have everything calm down a bit than watch them be right on the edge. Ventricular fibrillation is our arrest rhythm, so if they go into this, they definitely need the defibrillator or the precordial thump. It's chaotic, so there's no rhyme or reason. There's no atrial, the SA node is not got any control. It's the ventricles just fluttering. And you look at these hearts, and there's no actual organisation even of a ventricular beat. They're just fluttering. You can get fine or coarse, so sometimes fine ventricular fibrillation can almost look like a flat line, but if you turn up your amplitude, you actually see that it's not a flat line. This is just an example on our machine of a fibrillating patient. I did just look through my phone getting a heap of videos. I don't actually know exactly what was happening with this patient, but that's a shockable rhythm. So cheat sheets I'll give you at the end. Well, I'll make sure I get this PDF to you, so it's just something to keep prompting and reminding. I guess my key take home for this is if you've got a multi-parameter, put it on everything. Your normal spay. Get used to using it all the time. You can very quickly get these on, and you get used to what normal is. So then when something's not normal, and especially having patients under GA, it's the best time to learn. You know what not normal looks like. Go through your interpretation steps. Take videos. You can look back at them and review with someone who's got more experience and learn. So that's how we've all learnt in ICU. It's something some of my nurses are actually better at ECGs, I feel, than me. Hayley diagnoses some amazing complex arrhythmias, which there's a lot more arrhythmias that you can diagnose that I didn't have time to go through today. Getting a good cardiology text, if you're interested in this, learning, there's so much online as well that you can teach yourself. But yeah, I think the biggest thing is just to have the confidence that you don't need to know it all to start, and be confident with what is normal first, would be my take home. We've got a few minutes for questions. I did have a good question before, actually, of using the human machines on animals, and do we have problems with the blood pressure? Depends on the brand of the machine, and whether we do use human machines, and we have used the pediatric cuffs, and we make sure we go into the pediatric setting and not in the adult, which isn't as sensitive. But they've already tried that, and it wasn't working. It just wasn't reading their blood pressure. So I guess be mindful. Talk to the veterinary ones. I don't know all your brands over here of which ones are more validated and you're happy with. But it's something, again, if you can get one free or ex-hospital, it's always worth trying, because we have used a lot of human machines on them quite successfully. But always validate it. Get your Doppler, or if you've not got another way of measuring BP, get confident that it's real. There's so many ins and outs of non-invasive blood pressure, and sometimes you may be getting a number, and whether that number reflects the patient. Assess the patient, do your physical exam, feel your pulses. Can you feel dorsal pedals down on your dorsal pedal pulse? If you've got good pulses down there, your mean arterial pressure is greater than 60. Whereas if you can't feel pulses everywhere and you're getting a really poor blood pressure reading, it's probably real. So just a comment on that. But oh yeah.
Hi. So, thank you for the lecture. It was really nice. This is not an emergency case though, but it was an anesthetized dog, and we used the regular protocol. we attached the multipara to him. We had actually previously, a month ago, done a surgery on him.
Yeah. So
And
the same dog had
The same dog.
Yep.
It was a 2-year-old golden retriever.
Yep.
Okay. And the second time when we had done the surgery, anesthetized him, going in for surgery, attached the multipara, and then suddenly we started seeing VPCs.
Yep.
It was not tachycardic. It was normal. And then suddenly the VPC started happening at least 5 in a minute.
Yeah.
So we aborted the surgery. We sent for an echocardiography, and everything was normal.
Yeah.
So
What were you doing surgery for? What underlying?
it was an FHO.
Okay, yeah, so not systemically unwell.
No. And everything was done prior to surgery.
Yeah.
The first time. So when we went, the second time when we went into it, we didn't really do a checkup because it was a month later.
Yeah.
So is there any correlation?
Oh, look, it's hard to know. I guess that's something where our guys would probably do a Holter monitor where they'd have an ECG on it for a day and then have a look at how many abnormal complexes are we seeing, and is that sometimes, have your changes in, resting membrane and threshold potential with drugs slightly altered. I don't definitely know. We would look at that more intensely with a Holter and see is there any because structurally the heart could be normal, but there may be a problem with the electrical activity and they're more prone. What breed?
Golden Retriever.
Golden Retriever. Yeah. We would look at that more with a Holter and see, because it's not normal if they're happening quite frequently. There's a degree of ventricular arrhythmias which they will call normal, but they're very occasional. Yeah.
So is there anything during the surgery, or I could have administered to monitor and watch, or aborting it was a good idea at that time?
Look, if there are any occasional VPCs, they won't affect them hemodynamically. You would want to, but if you've got it doing an elective procedure, you're always better off to abort and get it checked properly. We would just be ready to treat with lidocaine. So I'd know my doses, and it's something where if you're using 2% your standard lidocaine concentration, the dose rate off the top of my head is I draw up 1 ml per 10 kilos, and that's 2 mg per kg. So I'm ready. So a 30-kilo dog, I've got 3 mils ready to go. And I know, the team know what they're monitoring for. So sometimes we do need to anaesthetize dogs with ventricular arrhythmias. Where does there to treat if it's getting to any of those more malignant ones?
Thank
All right.
you.
Thank you so much. Thank you, Dr. Ellie. And can we have a huge round of applause for her? Thank you, everyone.